Hello, this is Dr. Ford Brewer with Prevmed, heart attack, stroke, cancer, dementia prevention. All these conditions are not so much problems with the brain or the heart as they are problems with arteries. So we're going to be talking about lipids, cholesterol tests. We did a recent video on them. We just scratched the surface. There are other issues, especially on this one. We'll be talking about triglyceride over HDL ratio. That sounds confusing, but just hang in for a minute and we will understand why it's so important. It's actually one of the most important things and the most common thing that I see neglected by other physicians and patients. triglyceride over HDL is an indicator of diabetes and insulin resistance. So let's go back to the other ratio that everybody remembers and is pretty obvious and intuitive, and that is total cholesterol over HDL. With women, if you get 4 or more, and men, if you get 5 or more, you start getting significant increase in heart attack and stroke. However, when you think about it, those again are pretty obvious. And when you think about it, about 3/4 of heart attack and stroke related risk and inflammation in arteries tends to be driven by insulin resistance and diabetes. Most of the insulin resistance patients being totally unaware. So we'll get deeper into that in a few minutes, but just to remember, we're going to be talking about LDLs and HDLs. And remember the concept. The HDLs are like an empty dump truck. LDLs are like a full dump truck. The empty dump truck, or the good, HDL is known as the good cholesterol. So the empty dump truck is good. It can help pull lipids out of the way. You'll see several images again of lipoprotein particles. Lipo meaning fat or oil, and protein is what the body uses to keep these lipids from forming way too large a particle, keeping that particle microscopic and keeping us from having a fat embolism. Now, we've talked many times about plaque deposition. Plaque deposition occurs when the endothelium gets cracks in it, and LDL slips through those cracks and starts piling up. Then the immune system starts recognizing that plaque as something that shouldn't be there, and it starts attacking it. But let's go back. We started talking about diabetes risk and triglyceride over HDL. Here's the simple numbers, and if you're good at memorization, then you can listen for about 15 more seconds and then you're done. But if you're somebody like me that needs to understand what happens and why things happen, you may want to listen further. Because we'll talk about why does triglyceride over HDL indicate diabetes risk or insulin resistance. So you do have some racial variation with triglyceride over HDL. Of even 2 or more in non-Hispanic blacks, you do begin to worry about risk. With Hispanics and Caucasians, you tend to get higher numbers. So you look for more of a 3 or higher, or 3.5 or higher, for those groups to show risk for insulin resistance. Let's look at an example. This patient has a total cholesterol of 247, direct HDL of 28, and a triglyceride number, trying to get that in focus, triglycerides of 1240. Well, the ratio here of triglyceride over HDL is 45. And as you may remember, I just said 2 to 3 for blacks and 3 or more for Caucasians and Hispanics. So this patient obviously has huge risk. Well, actually it's beyond risk. This patient has known out of control, known diabetes, and it's, by the way, at this point, in very poor control. Their hemoglobin A1C was 9.8. remember, we would target below 5 for hemoglobin A1C, and their estimated average glucose from that number would be 235. So just cranking along on a daily, hour-by-hour basis of a blood sugar over 200. Well, what did their inflammatory panel look like? Well, as you might guess, there's significant inflammation for this individual with a microalbumin creatinine ratio of 50.1, excuse me. And with, again, normals are less, 4 or less. So this individual had very significant, if you remember the image of the glomerulus, where that's the filter, the endothelium of the artery, lots of cracks in that endothelium where that albumin is spilling out. So just a couple of other points about the lab tests for CHL. They tend to go back and then put all the positives back in a row. And with this individual, you've got C-reactive protein, microalbumin creatinine ratio out of control. But again, probably because or for sure, because this patient's got poorly controlled diabetes. Now, this is not a subtle picture. Usually, and one of the most important things we do in our practice is we will pick up individuals that have had evidence of insulin resistance for years, clearly even decades. And insulin resistance will damage your arteries even before you get full-blown diabetes. So what we'll see routinely is a triglyceride over HDL ratio of 3.5, 4, 5. Now, what causes this problem? It's called the dyslipidemia of type 2 diabetes, and this is a academic article on it. Well, in order to understand that, it helps to go back and understand actually a couple of other things. Number one, what is the actual particle, these lipoprotein particles? Well, you have a phospholipid layer that has the phosphate layer on the outside and the lipophilic layer so hydrophilic, or in other words, hydrophilic facing the water, lipophilic facing the cholesterol and triglycerides. LDL has very little of this protein, 25% or less, and HDL has a lot more. So it's empty, and HDL is empty. LDL is more full. What happens with the triglyceride problem is this. We shut off our mechanism. Insulin shuts down a hormone called hormone responsive lipase. When that happens, we can no longer burn fat. We live off of glucose alone to try to burn that glucose up. So if we're not able to burn fat, we're not burning triglycerides. Triglycerides begin to go up, and they stay there. So for hours after a meal, you'll get high triglycerides. Now, what causes the low HDL? By the way, if you want to get a little bit deeper in terms of that hormonal theory of fat or weight control, go to Gary Taubes. We've got a video on it. It's called, he's written several books on it, Good Calories, Bad Calories, which is a long book and pretty repetitious. His more recent book, Why We Get Fat and What to Do About It, is a much easier read, much clearer, much quicker. But it makes the point that we get increased glucose in our blood. Insulin is the response, and insulin then shuts down the lipase activity, the enzyme that breaks down fats and triglycerides. So guess what happens? You start getting, with increased triglycerides, there's a protein called cholesterol esterase transfer protein. It starts transferring all that increased triglyceride to an HDL. When it does that, it turns the HDL into an LDL or a VLDL, very low density lipoprotein. So again, this brings up the point we've made a few times, that there's very little differences in reality between all these lipoproteins. HDL and LDL, for example. It's just that HDL has less cholesterol. It also, as you see here, has less triglycerides. As you look at these other ones, VLDL, and there's also an IDL, intermediate density lipoprotein, there's a huge variation in triglycerides. So what's happening is this. Again, high blood sugar causes insulin release. Insulin release causes shutdown of lipase, the enzyme that allows us to burn fat and live off of fat. When we're not able to burn fat anymore, the triglycerides increase. The triglycerides are then transferred over to HDL, which turns them into LDL. So here's actually an image of this. Here are the triglycerides. Here is the LDL, and here is HDL. So you get an increase in triglycerides. They are then transferred by a protein called cholesterol ester transfer protein. They are transferred to the HDL, and that creates LDL out of the HDL. So again, now, believe it or not, that's actually a very simplified version of what goes on here. There are other issues as well. Glycation. Remember when glucose bonds covalently to proteins? Glycation tends to cause increased breakdown of HDL because of some receptor issues. In addition, it causes decreased breakdown of LDL. So again, more reason to see continued increase of LDL and decrease of HDL with diabetes and insulin resistance, and spending too much time with high glucose and high insulin. So this is another way of looking at this. This is basically relationship of small LDL to the triglyceride HDL cholesterol. So as you see here, these are small LDLs. These are the ones that are dangerous. These are the ones that cause problems. These are the ones that you can call fat bullets. They slip through the cracks in the endothelium. As the triglyceride HDL ratio increases, those small dense LDLs increase. So not only are you getting an increase in LDLs with this problem, you're also getting an increase in the fat bullets, the family of LDLs that are by far the most risk. So, as you start to put all this together, you start to realize there's a very definite connection between insulin resistance, increased glucose in our blood, increased insulin in our blood, switch from HDL, the good cholesterol, to LDL, the bad cholesterol, and in fact, the worst subpart of LDL. And that is why this is important. Just real quick, what do you do for that? Obviously, some of the things that we've talked about before. Weight loss, decreased carbohydrate intake. That's why we're recommending to a lot of people that they get a fingerstick glucometer at the drugstore and a few test strips and start testing themselves 4 or 5 times a day for a week or two to see how their glucose metabolism is working. That's why we get oral glucose tolerance tests, a much more definitive test than just hemoglobin A1C. So again, this is what we do, this is what we're looking for. We're uncovering hidden or unrecognized insulin resistance.